Okay, let us start. Hello everyone, this is Lefteris Tapakis and I welcome you to this webinar series for improving the quality of clinical case reports in homeopathy with particular reference to COVID-19 case reports. This is the second webinar of the series. The first webinar, which took place last Saturday, is now available on the YouTube. Just search for Vithoulkas Compass on YouTube and you will find it. Our host today is again Andrea Tsokanas, who is a valuable member of Vithoulkas Compass team. Hello, Andreas.
Hello, everyone.
In the panel, we have Dr. Robbert van Haselen. Good afternoon, Robert.
Hello.
Dr. van Haselen has done for many years great work on developing guidelines for homeopathic case reports with many publications in this field. We have also Dr. Chetna Lamba, PhD. Hello, Dr. Chetna. Dr. Chetna has done extensive research on the criteria for evaluating if a homeopathic treatment has acted in a clinical case report. These criteria are called the Modified Naranjo criteria for homeopathy with the acronym MONARCH. Dr. Chetna Lamba has done a PhD on this project and will guide us through these criteria later today. In the panel, we also have Professor Theodore Lilas. Dr. Lilas is an assistant professor of the University of the Aegean and is the head of the R&D research and development team of Vithoulkas Compass. Hello, Theodore.
Good afternoon to everybody.
We will have the chance to attend the presentation from Professor Lilas in the next webinar. And last but not least, we have Eirini Micholitsi, a distinguished member of our team, the VC team, a graduate of the International Academy of Classical Homeopathy. Eirini will show us how we can submit a case and through Vithoulkas Compass and present us an interesting old pneumonia case from our homeopathic literature.
Hello, everyone.
Now, the program today is as follows. First, we have Dr. Robbert van Haselen for further elaboration on the guidelines for a proper homeopathic case report. We are very much anticipating this presentation. Then Eirini, as I said, will guide us through the program and show us how to present a case. And also she will show this very interesting pneumonia case. Then I will show a very interesting COVID-19 positive case that was submitted to us through the Vithoulkas Compass template. This is a case that was submitted by a Greek doctor called Dr. Maria Pepa. And after this, Dr. Chetna Lamba will guide us through the criteria for assessing a homeopathic treatment. Then, in the end, we'll have a discussion and try to answer to the questions. If you have questions, please write them in the Q&A part, and we'll answer in the end. If you have comments, please write them to the chat part. Now, because the program is tight, we go immediately to Dr. Robbert van Haselen. Dear Robert, it is an honor to have you again with us, and the floor is yours.
All right, thank you very much, Lefteris. Let me just share my screen so get into the PowerPoint. You can see my screen?
Yes.
Okay, good. Right, so thank you all for joining us again. So my main objective of this introduction is to give you a fairly short and concise overview of working with the HOM-CASE CARE guideline. And just for those who were not there, just a 1-minute recap. So I will give this brief overview of the HOM-CASE CARE reporting guidelines, and I'll make just a few notes on some COVID-specific considerations. But I think it's quite important that we ideally we would like to have some time left at the end for these COVID-specific discussions. So I'm going to keep that fairly concise. So just a very brief recap. There is 2 elements here. One is the CARE guideline. And as I explained last week, the CARE guideline is a generic guideline for all clinical case reports. So these items, which are here shown in the CARE checklist, they apply for any kind of medical case report. And so then I explained last week that I developed, in collaboration with a team of about 25 experts, a supplement named HOM-CASE to the CARE Clinical Case Reporting Guideline. And this was published in early 2016. And so if we now look at this HOM-CASE CARE extended checklist, that what you can see here highlighted in green are the core items of the HOM-CASE part that we have added to what is not highlighted in green here, to this generic CARE clinical case guideline. And so just for a few minutes now, I'm going to take you to this checklist. So this is essentially the same checklist, and I'm going to take you through this checklist, and I'm going to make a few observations. And I would like to really thank a lot Dr. Chetna Lamba, who will be speaking after me, because as part of her project, which she will explain, she actually did trawl the literature for published clinical case reports, and ultimately she reviewed 62 published case reports. And so I'm really grateful for her advice and tips, her experience when reviewing those cases, what were the kind of things that were most often missing. And so, but just as a very brief overview, this is sort of what I referred to last week as the architecture of a clinical case report. So you could say this is the skeleton here on the left, metaphorically speaking, and on the right, this is the meat on the bone, effectively. And this skeleton is basically nothing new. The skeleton is the skeleton of any kind of scientific project. Because if you look at these items here, then you see title, abstract, patient information, findings, intervention, outcomes, and if we skip to the next one, you see discussion. This is the basic structure of every scientific paper. If you publish a randomized controlled trial, you have a similar structure. You have a title, you have abstracts, you have an introduction, then you have your methods, then you have your findings, and then you have a discussion and conclusions. So this basically is a scientific way of looking, in this particular instance, at clinical case reports. And one thing is already quite clear is that often when you look at published case reports, there is no abstract. It was very often missing. So again, I'm emphasizing now in this short introduction, particularly the things that were missing. And you will find that this as a note in orange font type. All of you will get at the end of this seminar, we can send you this checklist in a Word and in a PDF format, because the idea is that you should start using this checklist also when you may be reviewing your own cases, where you say, oh, I have this great case which I want to share. Then you would use the similar checklist to say, okay, even if I go initially my medical records, are my medical records complete enough? Is this case report sufficiently complete? So then you see the introduction, and the introduction should normally include also some reference to the medical literature. So for a COVID case report, you would want to refer to some of the latest information or the most recent publications on COVID cases, what's known on about COVID cases. But again, surprisingly, this is often not reported. Unsurprisingly, this is often not reported in case reports, published ones. Now, this section about information about the patient, like demographics, the main symptoms, sort of the history, and relevant past interventions and their outcomes, this is relatively well reported, because this is the kind of thing that that's sort of really also the basis of most sort of homeopathic case reports. Is you would want to mention this, even if it's a case report, a case that you share with your colleagues. Usually you would want to share this type of information. Now then there's clinical findings, and here you see in yellow, and you can see I have coded it here 6H1. In other words, it's item 6 in the care guideline, but this is the first specific homeopathy extension item. And here is like, you want the clinical history detail from the homeopathic perspective. And in particular, you would like to know what homeopathic symptoms were used in the whole decision-making process. So that would include like a repertorization, symptoms used in the repertorization. Now then the timeline, this is a very important element, because the timeline is a bit like a helicopter view. So it's like you take off, and you really want to see in this timeline, in a sort of a chronology, very briefly, what's happening with this case. And last week I mentioned this, showed you this one. This is a very fancy one, where you see, okay, you start with the history here at the top, the background, what was the presenting complaint. Then you see, okay, what were the things that happened at which date, and okay, what intervention took place, what were the changes following the interventions, and ultimately here at the bottom,
we have problem with the sound, huh?
Yeah, it looks like. Robert, can you hear us?
I think this problem he has to log off and log in again.
Yeah,
Okay,
that's
so
right.
we will wait. So we have seen up to now the basic features of the home care guidelines, and this feature will be followed by me in the case that I will report later. So these features are implemented in the template that we have in Vithoulkas Compass. So now we will wait for Robert to join in again and continue his lecture.
all right, I'm back, sorry.
Okay.
I got thrown out.
Welcome back, yes.
Sorry about that. So let me go back to my PowerPoint. Yeah, sorry about that. So, so this is the same structure essentially as this fancy graphical one. And if Susanna agrees, we can share this timeline as a Word document with the participants, just to facilitate this process. So then we're moving on to diagnostic assessment. And as you can see here, this is quite often missing in case reports. And for instance, diagnostic challenges are almost always missing. And for instance, for COVID, this could be that the patient had suspected COVID, but we were unable to obtain a test because maybe this COVID test was not available. And you see actually in this COVID epidemic that a lot of these cases, they have these challenges around getting the COVID diagnosis confirmed. But again, generally speaking, the diagnostic reasoning and the challenges faced are relatively poorly represented in homeopathic case reports to date. So this is definitely an area for improvement. And then we're looking at the therapeutic intervention. And here you see some of these yellow things, again, which are the homeopathic, the HOM-CASE CARE extension items. And you can see that this is mainly about, okay, what about the type of homeopathy? In some cases, it can be useful. What was the basis for the prescription? Was it keynotes? Was it totality? This kind of information is useful. And here is like the medication. But again, it's very important to be detailed. In other words, not just say 30C, but if they were granules, they were made by manufacturer X or Y, it was corsacovium or hahnemannium. So it's important to have detail in here. So then we move on to follow-up and outcomes. And here you see that for the homeopathic cases, we have added this element of objective evidence. But you see here also the notes that very often adverse events or unanticipated events are missing. Now, we know, of course, that in most cases there are no adverse reactions, but it's very important to mention this, even if it's a very single line. No adverse reactions were reported. So the absence of something is also important to mention. Right, so then here we look at occurrence of homeopathic aggravation, which is also a homeopathic item. And then what you see here, the possible causal attribution of changes explicitly assessed and discussed. And again, the finding is, if you go into the literature, that this is very often missing. And this is also why Dr. Chetna Lamba is going to help and explain how we can do that better in the future. Now here you see a lot of orange. The discussion, every scientific paper, for if you publish a clinical trial, something like that, there will always be a discussion. And the discussion is where you as an author, you can give your personal touch to this. You can say, well, the strength of the study was, my main finding was such and such and such. And the strength of my case report was such and such and such. But there were also certain limitations. And then you would in your discussion say, well, the implications of these, the contribution of this case to our knowledge on COVID is such and such and such. Now, this is kind of a scientific thinking. And you will see the same structure in every scientific paper. But in a way, the same structure you should apply when you share a case report with your colleagues. And this is where you really can give your personal touch. All the other elements, in a way, you just have to report the facts. And the purpose of a guideline is really that you make a factual report so that your colleagues, in a transparent way, that you say, this is what I've done, these were the outcomes. You give that transparency to enable your colleagues to form their own opinion. Except for in the discussion. In the discussion, you can give your vision and your outlook on, what you're contributing to the literature. Now, what you can also see, patient perspective, very often missing. And this is very interesting because we need to develop a patient perspective where really the narrative of the patient. And ultimately, this is what it's about. And it's kind of paradoxical that we report cases and that this very fundamental narrative of the patient is very often missing. And then a more formal aspect, did the patient give informed consent for their case to be reported or not? And again, this is often missing, and really these things need to be addressed. Then we are giving in this checklist some definitions, but I'm going to skip that now because I really we have a tight program. So I'm going to move on. And these are suggestions. These are not absolute truths, but these are suggestions for, okay, homeopathic aggravation, this is how you could look at it. If you have another view, you can do that, but then you need to be transparent. Why do you think, why you have defined your aggravation differently? So it's all about transparency. So to conclude, very important, it's not necessary to strive for perfection. And often when we look at this checklist and you go at the HOM-CASE CARE checklist, then you notice there's things missing. And people tend to think, oh, that's really bad, and they feel bad about that. And it's normal that there will be some bits and pieces of information missing because case reports, they represent kind of this messiness of the real world. The strength of the case report is that it's as the closest as possible to the real world of clinical care. But we all know that the real world is a bit messy. Maybe you have a full waiting room and you're already running behind in your clinic, so you didn't have time to collect all this information. So it's normal that a case report also represents some of that messiness, that you don't have everything. But it is very important to strive to be more comprehensive and to transparent. And as I said, you should think that you should bear in mind what you share should enable your colleague to form his or her own opinion. And I always say, when I give seminars and workshops, writing a high quality case report, it's both easy and it's hard at the same time. And I just want to leave you with this also as a reflection when you're going to write up your own case report. Thank you very much.
Thank you very much, Robert, for this very interesting presentation. Like you said in the first presentation last week, it is not rocket science. It is something that is relatively easy to be done. At least someone dedicates some time to it that will help him also understand the case better. So now we continue with Eirini. Eirini will help us, will show us how we can submit a case, and also present us a very interesting pneumonia case from our homeopathic literature. Eirini, I'm passing the microphone.
Hello, everyone. So I will be talking about something more practical. And this will be how to report a COVID-19 case using Vithoulkas Compass homeopathy software. I hope you can see my screen right now.
Yes, yes.
Okay.
Good to go.
Okay, so I would like you to know that all this information will be provided to you, so you don't need to take any notes. There are two options. You can either submit your case using a Vithoulkas Compass account or by email at lmhi2020@vithoulkascompass.com. Please mind that if you're not a user already, you can subscribe using the coupon COVID-19 for a 1-month free access so that you can be more familiarized with the use of the program. So I will start with option 1, and I will make use of an example that was reported at the Hahnemanian Advocate Monthly Magazine. It was a pneumonia case reported in 1898 by Dr. R.M. Barrows, and it was a case of a 20-year-old young man. And just because our schedule is very tight, I have gathered all the symptoms and I have put them in a list. So the symptomatology included severe chill, pain in the right side, pain worse lying on the painful side, distressing cough, eyes red and watery, profuse sweating, red face and eyes, increased thirst, pneumonia attacking the right side, fever of 39.8, rapid bounding pulse, constant cough with blood-streaked sputum, pain in the right side extending to armpit, congestion in right lung in lower and middle lobes. So as reported by the medical doctor, there were 3 prescriptions for this case. The first one was belladonna 40 mg that acted very well. But after a small relapse, the doctor gave aconitum naprinus 50 mg that did not act very well. And finally, the case was resolved with veratrum viride 50 mg. So if we assume that this is a suspected COVID-19 case or whatever pneumonia, so what we need to do is we follow the steps as I'm going to show to you. First, we visit the website of VithoulkasCompass.com. And we log in or we register. I'm going to log in because I'm already a user. And as soon as I see this interface, I go to the tab My Cases. And I click on a new case. Okay, so I'm going to choose a title. Let us say Hahnemanian Advocate. My main complaint is pneumonia. We have a male of 20 years old. And then we create a case. So in order to save more time, I have already created this case. So you can see that as soon as I click on the case, I have the case history that refers to all my prescriptions and the analysis and their repertorization and the case notes. So this is the field where you can fill in all the information about your case, but especially for submitting a COVID or a suspected COVID-19 case, you further need to go to templates and you need to click on the LMHI COVID-19 clinical case report submission form. So as soon as you click on that field, down below your case notes, there will be the submission form that abides by the criteria that Dr. Van Haselen has been elaborating on. And Lefteris Tapakis will explain further in detail all the information you need to fill in by giving some solid examples. So this case was poorly documented. So there can be no, I have not filled in the criteria, but I have made the repertorization, and it's very interesting to see that by using 12 rubrics, the results show that the remedy is quite clear. And the first remedy is belladonna, which covers 12 out of 12 symptoms. And what is very interesting is that veratrum viride comes actually second, although it covers 8 out of 12. So that might indicate that belladonna had made the picture more clear. So as soon as you fill in the repertorization, the case submission form, and all the other details, you close your analysis, you close the case, and you go back to the list of your cases, and then you click on Send to the recipient field, and you type LMHI 2020 so that we receive your case and make an evaluation. So that will be all. And in order to help you out with this process, I have made all the screenshots available for you to see. So I'm going to get through all this very quickly. And in case this process seems too hard to do, you can opt for number 2 option, which is to send your case by email. So what you need to do is visit the following URL, download the LMHI COVID-19 case report submission form, fill in all your details and send it to the lmhi2020@vithoulkascompass.com email account. So this is what you should download, and I think that will be all. And please, for any further inquiries or assistance, do not hesitate to contact us by email at lmhi2020@vithoulkascompass.com. Thank you very much, and I hope we have some good results to show.
Thank you very much, Eirini, for showing us how simple it is to submit a case and for the very interesting pneumonia case. Now, I continue by showing to you a very interesting pneumonia case that we received. This is a case that was submitted to us by Dr. Maria Pepa, his colleague, a graduate of the International Academy of Classical Homeopathy, a student of George Vithoulkas, that sent us this case. And this is a case of actually a doctor, a friend of hers, that works in the UK. It is a 43-year-old woman, a doctor that lives in England. This is the template that one has to follow in order to submit the case. Just like Eirini showed, you go to templates, you pick the LMHI COVID-19 clinical case report, and the template opens and you fill here your case, which guides you in which helps you actually in what to write, in what elements need to be pointed out. Okay, here is an introduction that we see. Here it says rate. Ideally, the COVID-19 diagnosis should be confirmed by a lab test. And in this case, we do have a positive COVID-19 lab test. Then we see rate the severity of the illness. It is a case of moderate severity. Here, record and report as much as possible fever, including the number of days after the treatment there was an abscess of fever. The response was 6 hours after the remedy, the fever subsided, and she has no fever since. Record and report as much as possible the number of hours, days after the onset of symptoms the homeopathic treatment started. So this patient had fever for 7 days, and in the 7th day she took the homeopathic remedy, and the results happened in 6 hours after the remedy. Up to that time, she was only on paracetamol. Okay, here it writes to the doctor if he or she has more COVID-19 cases. This doctor says no other confirmed cases. Okay, submission criteria. If there is objective data, yes, the fever is an objective data that we have. If we have the consent from the patient. Yes, we have the consent from the patient, and I want to thank the patient, the colleague, the doctor that gave her consent to present this case. I excluded identified data from the patient, okay. Okay, then here is the doctor's information, Maria Pepa, general practitioner from Crete, Greece. Sources, the care guidelines that are implemented here. So here it says a case report has to have a title, and the title has to have the words case report. So a possible title would be a case report of a COVID-19 positive 43-year-old female medical doctor treated with classical homeopathy. Keywords. 2 to 5 keywords, COVID-19 positive and classical homeopathy. Introduction. How it contributes to the homeopathic literature. It is a COVID-19 positive case with fever and pains whose clinical picture improved dramatically after the administration of the homeopathic remedy. Patient information like demographics, comorbidities. This is, as we said, a 43-year-old female Bulgarian medical doctor that lives in the UK and suffers from chronic Meniere's disease, a mild chronic Meniere's disease, no other chronic illnesses. The clinical findings, we have as a test the confirmed COVID-19 positive test with PCR. Here it says, to be precise, how the temperature was taken. The temperature was taken from armpit. Okay. And now we have the homeopathic clinical history details, including the homeopathic symptoms used for the remedy decision. Okay, symptoms started on the 11th of April. The patient started feeling unwell with sore throat, running nose. 2 days after this, she became worse with headache, watery eyes, anorexia, chills, fatigue, nausea. At the 18th of April, we have fever until 38.5. She was feeling very bad, generally with nausea, muscle pains, intense muscle pains, pain in the bones, pleurisy, chest pain because of the dry cough, and she was keep taking paracetamol 3 or 4 times per day. The doctor writes, I was informed about her condition on Monday, 20th of April, but she could not find homeopathic remedies and she had ordered them through internet. Now, till Friday, 24th of April, that is about 1 week after, with the fever continuing, he was only on paracetamol. On Friday, she was worse. She could not get up from the bed. She was sleeping during the day with fever, muscle pains, bone pains, nausea, chills, pain in the thighs, sensation that the bed was hard, headache, and at the last she received the homeopathic remedies. At 21:00, she took 1 dose of pyrozenium, 1 m, and she repeated at 23:00. I had consulted her to stop taking paracetamol till we see how the fever is going. And 6 hours after, she woke up at 3:30 in the morning with no fever and with her appetite coming back, and she could eat and drink. And until then, she has no fever. After this remedy, on the 2nd of May, some days afterwards, She was also prescribed muriatic acid 1 mg because of the weakness that was remaining. And also muriatic acid helped for the weakness. Here we have the timeline, a concise timeline. 11th of April, we have the onset of the symptoms. 18th of April, we have the fever, that raised with pains, fatigue, anorexia. 1 week after, the fever was continuing with chills and the condition remaining bad. In that day, she took the first remedy, the pyrogenium 1 mg, and hours after 3:30 a.m., no fever and appetite returned. And then 2nd of April, she took the muriatic acid 1 mg. Okay, diagnostic, focus, and assessment. What type of repertory was used, type of symptoms, etc., etc. So these are the symptoms that were used: head pain, appetite wanting, nausea, cough, painful, extremities pain, influenza during, extremities pain, bones, pain thigh, pain, aching in the extremities during chill, very intense chills, shaking, shivering, rigors, fever in general, cold. She was cold. She had the sensation, generally this hard bed sensation of that the bed was hard. Influenza-like symptoms, muscle in the pains, and pain sore, bruised on lame parts. And this is the remedies that Vithoulkas Compass proposes. First pyrogenium and then Eupatorium perfoliatum, Eupatorium perfoliatum. And the pyrogenium covers 11 out of the 15 symptoms, with first the pain, aching during chill, the influenza-like symptoms, and the pains in the extremities, a case that was looking almost like a septic one. I think that was the reason that the doctor picked up also this remedy. Now, therapeutic intervention, individualized homeopathy. Describe the form of the homeopathic remedy. It was by Korsakoff method, pyrogenium 1 mg, and here's the link from where she ordered the remedies, the pyrogenium and the muriatic acid. The follow-up and outcomes, we said that 6 hours after the pyrogenium, there was improvement, the fever subsided, and but the weakness remained. Dr. Chetna Lamba told me that we can ask the patient if during these 6 hours, if there was a further elevation of the fever, and if during the elevation of the fever, the patient started feeling well already. We didn't have the chance to ask this question, but we will do it. Now, the discussion, the strengths and limitations, as Dr. Robbert van Haselen said before, we have not also stressing the strength of the cases, but also the limitations of the cases. And in strength of this case is that we have also a COVID-19 positive test, of course, and the limitations is that we don't have many other objective findings. That is, we don't have X-rays, oxygen saturation, pulse, and pulse. Learning points from this case, I think the main learning point is that homeopathy should be individualized, that this was a prescription based on the characteristic symptoms of the patient. And last but not least, we have the patient perspective, which is optional, but here we have a very nice testimonial from the patient that I would like to read you. So the patient writes, So I would like to share my experience with the homeopathic treatment I have recently received for infection with COVID-19. I'm not very familiar with homeopathy and have never trusted this way of treatment, even though I do not know much about it. But my very recent experience made me change my mind and created a different opinion about it all. I trusted my good friend and a doctor who advised me to buy and try Pyrogenium 1M during my illness. I was feeling very unwell at the time, had spent days on and in bed with fever, nausea, myalgia, and extremely tired. I was up to try anything as long as there was any chance to get better. I did not expect the homeopathy to help me actually. This is part of the medical science I do not understand and have never considered as treatment option. You can imagine my amazement when I woke up and felt good in my skin for the first time in an almost a week, only a few hours after taking Pyrogenium. I could not believe it. I was not able to explain it. Honestly, it felt like a miracle. More like so as the time I was starting to give up hope that I will ever get better, as there was no any treatment available. How I feel about homeopathy is easy to describe. I discovered a new world of medicine I did not know existed and where miracles are possible to happen and do happen. I'm really interested in learning more about it and explore new treatment options for problems I normally treat with antibiotics, paracetamol, etc. Thanks to homeopathy and the best advice I have ever received, I'm fully recovered and back to my feet again. Okay. So this is the case. Of course, we expect more cases because what we see is that homeopathy is really an option to the COVID-19 and to this influenza-like disease. And now I'm passing the microphone to Dr. Chetna Lamba to explain to us about her field of research, the criteria to evaluate a homeopathic prescription. Dr. Chetna, thank you very much for accepting our invitation to be with us today. We are very honored that you are here, and I'm passing the microphone, and we are very much anticipating your presentation.
So thank you, Dr. Lefteris, for a kind invitation. And it's really honor and privilege to be on this forum. First of all, I extend warm greetings from India to entire homeopathic fraternity. And without taking much time, I'll just come to my topic, that is MONARCH for the establishment of causal, that is cause-effect relationship of homeopathic intervention and clinical outcome in case reports. So we'll be just going through a very short history of case reports, the hierarchy of evidence, where the case report lies, its significance, challenges, causal assessment, and history, development, validation, and elaboration of MONARCH. So case reports are scientific documentation of a single clinical observation having a time-honored and rich tradition in medicine and scientific publication. You can just see an ancient medical writing, and probably the first case report recorded was on papyrus at around 1600 BC. And arguably, this can be the first step on the path towards evidence-based medicine. So they have traversed a very long history, we can say, starting from 1660 BC till few years back, when this hierarchy of evidence took over and the era of RCTs, meta-analysis, and systematic reviews came. So with this all, the case reports, they were pushed at the bottom line of evidence because they have a high risk of bias, lower quality of evidence, and the RCTs and meta-analysis, they started the domination. But eventually, for the last 5-7 years, we are seeing there is resurgence of interest in the case reports. As per a publication in 2015, a good number of journals are now based on case reports, and out of which I think about 40% are PubMed indexed. So what are the reasons for this resurgence of interest in case reports, and why this hierarchy of evidence is being questioned? Now the non-hierarchical perspective, this is the hierarchical evidence. Now the non-hierarchical perspective on evidence has been further developed and explained by several CAM researchers and referred to as an evidence mosaic, an evidence house, or a circular rather than hierarchical perspective. Now these approaches essentially organize evidence based on research objectives and not based on research design. Since none of the objective is deemed to be intrinsically superior to any of the other objective, no research design is intrinsically superior to any of the other research designs. So coming on to the simpler version of what I said is, instead of this hierarchy, now the people are talking about the evidence mosaic or the circular level of evidence, particularly for CAM and homeopathy, where we have personalized medicine, individualized approach. This is more suitable. When we go to the RCTs, they may have a very good internal validity. They have the methodological rigor. They have low risk of bias. But for example, if we are doing a study on polycystic ovary syndrome, we have a definite inclusion and exclusion criteria. The patients who fulfill that criteria based on age and other things, they are enrolled. Though we say that we are enrolling the patients from general population, they are representative of general population, but it is somewhat an artificial environment. Some of the rigors, some of the inclusion-exclusion criteria, which we can say that they improve the internal validity, but the external validity, that is the generalization of the results of such studies. That is a question we need to see. On the other hand, these case reports, they allow an in-depth, multifaceted exploration of complex issues in their real-life settings. It is considered when an experimental design is either inappropriate to answer the research question posed or impossible to undertake. So many a times we see in surgical conditions, the RCTs are really challenging. They are not possible to take. So again, the importance of case reports or case series resurfaces. Then for assessment of safety and the generation of hypothesis, case report is very important. If you can just go back to the history of case reports, in 1961, there was a thalidomide case report published in Lancet. And thalidomide was very commonly prescribed as an antiemetic during pregnancy. But as per the observations of Dr. McBride, he found that congenital abnormalities are present in 1.5% of the babies. So his observations in individual case reports, he reported, and this led to withdrawal of this medicine. So here, case reports come to a very important purpose. Then another is teaching purpose. As a student, we'll all remember when our teacher taught us with the live example of the cases. They taught us the picture of lycopodium or any other drug. Those such teaching methods which were based on case reports, they are still fresh in our memory. Then next very important thing is intrinsic freedom for reporting. Here, as Dr. Lefteris has shown his case, the author or the physician who treated the patient is free to share the case. She has reported it, definitely taking the consent from the patient and not identifying her age, her name and basic details. So here you don't have to go for the many approvals, the technical, administrative, ethical approvals which are associated with other study designs. So they form a very important option, and they have intrinsic freedom for reporting. And last but not the least, it is easiest to initiate into scholarly writing. Even the topmost researchers, when you inquire how they got initiated to research and all, it is how they developed this flair for writing. That usually dates back to some good case report which they successfully treated and reported. So case reports are really very magnificent in the way, the first point, which is they allow in-depth, multifaceted exploration of complex issues. Here, for example, a case of PCOS. Many of the cases of PCOS which are excluded as per your study design, but as an individual, as a patient, as a doctor, you can always treat them in your practice based with their real life problems. They may be having n number of comorbidities, they may be on n number of medications, or they may have some other challenges which does not suit the RCT model, but as a practitioner, you can treat them. Now, coming on to the challenges, the inherent challenge with the case report is the weakest level of evidence with regard to establishing cause and effect relationship. And these are insufficiently rigorous to be combined for data analysis, informed research design, or guide clinical practice. But if carefully conceptualized, thoughtfully undertaken, and reported, case reports have the potential to offer evidence from the point of care that can be useful for clinical research, guide clinical practice guidelines, and improve medical education. Now, improving case reports from evidence point of view, Dr. Haselen sir has very nicely elaborated on the care guidelines, home-CASE care guidelines, and then modified Naranjo criteria for homeopathy. And then the latest comes the MONARCH, which is nothing but a validated version of modified Naranjo's criteria for homeopathy. Now, this has been a very interesting journey when we go back to MONARCH, how this came into existence. Dr. Naranjo, he was one of the leading researcher, and he basically wanted some algorithm to identify whether in conventional medicine trials, the adverse event is related to drug therapy or not. So he devised this kind of an algorithm which could, based on a list of weighted questions which examine factors such as temporal association of drug administration and event occurrence, potential alternative causes for the event, drug levels, and previous patient experience with the medication. So based on all these things, he developed this Naranjo criteria. Then in 2013, Dr. Lex Rattan was first to propose that for assessing the causal relationship in homeopathic practice, it might be useful to develop an algorithm like Naranjo algorithm, and he felt that this could be adapted for homeopathy, and he proposed a modified version for the same. Subsequently, HPUS Clinical Data Working Group modified the version developed by Dr. Rattan further in 2014 and 2016 subsequently. And further, its validation was undertaken as a PhD study by me from Homeopathic University, Rajasthan, India, under supervision of Padam Shri, Dr. V.K. Gupta sir, and advisorship of Dr. Robbert van Haselen and Dr. Lex Rattan sir. Dr. Nidhi Mahajan and Dr. Abdul Matan Molla, they were the experts in this study. So this has been the outcome. This is the paper published recently in Homeopathy, and you can access it and go through the details. Now, what was the objective of this study? The objective of this study was to establish the reliability and content validity of modified Naranjo criteria as a tool for attributing a causal relationship between the homeopathic intervention and outcome in clinical case reports. So validity means whether or not the test measures what it claims to measure, and interpreter reliability is a measure of reliability used to assess the degree to which different judges or raters agree in their assessment decision. So the cases were sampled based on the following criteria. Inclusion criteria consisted of, I'll just show you the HOM-CASE CARE guidelines. Now, all these items from, can you share, can you see this? Can you see this HOM-CASE CARE extension checklist?
No, I think you have to again share your screen, unshare and again share to pick the right document.
Okay, okay, I'll do that.
Okay. Unshare your screen and then you can share it again.
Right, I'm doing that. So now
Yes.
is it visible?
Yes, yes, yes.
So these items from number 1 till the end, they were numbered from 1 to 30. And you can see those which are pertaining to homeopathic domains 6H1 and subsequently, they were numbered from 1 to 6. We left this 10H6 because this was a research question, that is possible causal attribution of changes explicitly assessed or discussed. So we left it, and other domains, the generic domains from CARE guidelines were numbered 1 to 30, and these yellow highlights were numbered from 1 to 6. So the minimum of 9 items, if any case report was covering, we included them for further study, and minimum of 3 of these yellow highlights, that is the homeopathy specific domains, if the case report covered, we included for further evaluation. So coming back again. Yeah, is it visible? Is it visible?
Yes, yes, yes.
So these were the included cases, and exclusion was based on the cases reported with poorly described prescribing symptoms and homeopathic patent medicines or compound formulations, proprietary products, or combinations where more than one medicine was administered simultaneously. Now, I'll be just reading out quickly the modified Naranjo criteria for homeopathy, and I'll just request you to think over that what domains are applicable to COVID-19 positive cases and specifically to the case which Dr. Lefteris just shared with us. So it has 10 domains numbered 1 to 10, and you have to assess them if you find that it is covered in your case report as yes, no, not sure, or not applicable. So as per the scoring, we can assign the score. First domain is, was there an improvement in the main symptom or condition for which the homeopathic medicine was prescribed? Did the clinical improvement occur within a plausible time frame relative to the drug intake? Was there an initial aggravation of symptoms? Did the effect encompass more than the main symptom or condition? Did overall well-being improve? Don't worry, I'll be elaborating them in my subsequent slides and just showing you the original previous version. So direction of cure, did some symptoms improve in the opposite order of the development of symptoms of the disease? Then direction of cure, did at least two of the following aspects apply to the order of improvement of symptoms, from organs of more importance to those of less importance, from deeper to more superficial aspects of the individual, from the top downwards? Did the old symptoms reappear temporarily during the course of improvement? Are there alternate causes that with a high probability could have caused the improvement? The ninth domain is, was the health improvement confirmed by any objective evidence? And last domain is, did repeat dosing, if conducted, create a similar clinical improvement? So outcome assessment was inter-rater agreement in the scoring of these domains was determined by calculating the percentage agreement and kappa values. Kappa is commonly used to measure that indicates the level of inter-rater agreement. Now here all the case reports which we had included in the study, they were evaluated as per this modified Naranjo criteria by 4 raters. And for myself, my PhD supervisor, Dr. V.K. Gupta sir, Dr. Nidhi Mahajan, and Dr. Abdul. So the range of kappa here is from 0. 0 is a chance agreement and 1 is perfect agreement. A kappa greater than 0.4 indicates fair agreement between the raters in conjunction with the absence of concerns regarding the face validity, that is, representative instrument or test is at face value as judged by experts in the field, and whether it appears to be a good instrument was taken to indicate the validity of each domain. So this is the outcomes. 60 case reports met the inclusion criteria and were assessed by 4 raters. And you can see that all the domains 1 to 10 are valid except 6A and 6B, which are pertaining to direction of cure. So the conclusion of the study was that modified Naranjo criteria for homeopathy causal attribution inventory was identified as a valid tool for assessing the likelihood of causal relationship between a homeopathic intervention and clinical outcome. Improved wordings for the several criteria have been proposed for the assessment tool under the new acronym MONARCH. So these 2 MONARCH domains, that is 6A, 6B, pertaining to direction of cure, require further assessment. Now, before I go and elaborate the 10 domains of MONARCH, I would just like to make a point that cases successfully treated can have a different treatment approach or strategy based on the nature of disease, susceptibility, and various other factors. So many times we may be successful with a single medicine, then the likelihood of causality is attributed to that particular medicine. But in real life situation, in complex diseases with comorbidities, it is quite possible that we may use series of medicines based on the changing symptomatology. Therefore, the likelihood of causality is to overall homeopathic treatment and not to a single medicine. So you don't have to worry or you don't have to bother that, oh, in this particular case, I've changed the medicine so often and I have used a number of medicines. Should I report it? I shouldn't report it. If you think it is a good case report, if the condition is not amenable easily to cure or remission as per the diagnosis, you should definitely report it. Don't stop by thinking that you have used a series of medicines. Now coming on to the MONARCH, elaboration of 10 domains. Here, what we have previously shared is the modified Naranjo criteria, and after the studies, some of the wordings have been updated, and these updated wordings are shown as underlined. In domain 1 and 2, you will not find any change because there was 100% inter-rater agreement. So domain 1 and 2, they are as it is. That is, was there an improvement in the main symptom or condition for which the homeopathic medicine was prescribed? Now, what is the main symptom or condition for which the patient reported? That is the disease diagnosis. And all symptoms of disease should be assessed. Now, coming on to a COVID case, for example, in this particular case, the patient had fever, the patient had many other symptoms. So what all symptomatology the patient or COVID patient is giving to you, be it fever, cough, headache, nausea, they all are to be assessed together as a disease entity for improvement. Now, coming on to chronic case, for example, like PCOS. Now, PCOS, it is a composite diagnosis. It is not based on a single criteria. Either we are diagnosing PCOS on the basis of Rotterdam criteria or androgen excess society criteria. So we are fulfilling their criteria to diagnose the condition. Likewise, when we are assessing the improvement, we should see that all those parameters have improved and then say, yes, there is an improvement in the main condition or the main symptom for which the homeopathic medicine was prescribed. Now, domain 2, it is, did the clinical improvement occur within a plausible time frame relative to the medicine intake? The effect of medicine should be within a reasonable time period of intake of medicine so that the causality can be established. Actually, this is your clinical judgment, and in acute cases, it is very easy. You're giving the medicine, patient is taking the medicine under regular follow-up. You can say, yes, it is within the plausible time frame the patient responded to the treatment. Now, what happens in chronic conditions? At times, the patient, you prescribe to the patient and patient didn't report for say 7-8 months. And one fine day when he comes back and you see some, that was a case of vitiligo, and you find some pigmentation in his vitiligo spots, and you think, oh, I prescribed this remedy 8 months back and could be due to that. But it is very unlikely. This time frame is it's not plausible. And before coming to any conclusion, we should inquire the patient. Did these spots appear when you took the medicine? If he says, no, I have just recently noticed them, then that plausible time frame is not there. So we should use our clinical judgment when we assess this domain. Next is domain 3. Was there a homeopathic aggravation of symptoms? Now, this is a very interesting domain, and you may not find it very frequently in clinical practice. So, but whenever you find it, it is characteristic of homeopathic system of medicine, and if it is observed, it can increase the confidence in the likelihood of a causal relationship between intervention and effect. For example, in a COVID case, here also in this particular case, the fever was high after taking a dose of pyrogen, but within few hours, the patient felt so much better. So this was probably a homeopathic aggravation which we could consider. Likewise, even in chronic cases, we may find homeopathic aggravation. As an acute, we may have it in a few hours. In chronic cases, we may witness it in few days. And if the patient is on 50 millisimal medicines, we may observe this aggravation at the end of treatment. So please don't worry, you will not see it often, but this shouldn't deter you from reporting your case reports if you are successful. Then domain 4, did the effect encompass more than the main symptom or condition? That is, were other symptoms not related to the main presenting complaint improved or changed? This is a very important domain to understand, because even when we were rating, there was some difference in understanding between the 4 raters. That's why we have added the sentence not related to the main presenting complaint. So I'll just give you one example from COVID. A patient, COVID positive case with fever, cough, shortness of breath, headache, myalgia is there. And with your medicine, patient improved. So you will not see this domain very often in acute conditions. But for example, if a patient already had vitiligo and he got COVID positive, and after your medicine from for this COVID, he reports, doctor, yes, my COVID, my fever and other complaints are better. What I find is after this medicine, some spots have, some pigmentation have appeared in my these white patches. So though this is a very bleak probability, but yes, that is a probability. Otherwise, in acute cases, you may not find it. Coming on to other conditions, like one is lesser accessory symptoms. Patient may come to you for his, say, any rheumatoid arthritis or any other complaint, and when you start with the treatment, patient comes in the subsequent consultation and says, oh doctor, I slept after 20-25 years. And you simultaneously open the case and sleep was reported to be normal. Then the patient says, oh, actually I'm so much used to that disturbed sleep that it's part of my routine. That's why I didn't report it to you. So such lesser accessory symptoms, if you are observing, kindly mention them, and they will again help to establish the causality. Another important thing is in multi-morbidities, where there are many comorbidities and patient is focusing on one particular diagnosis. If this is my main complaint and rest, okay, I'll manage, but you focus on this. But if you find that apart from the main diagnosis, other issues are also addressed, they are to be evaluated here. And in one small case I'd like to share, one surgeon with a red eye came in my practice, and she said, I have been to all the ophthalmologists, no one is helping me, do something. And when the medicine was given for her red eye, in the next visit, she said, how do you know that I suffered from severe knee pain? My knee pain is better now, but I didn't report to you at the first visit. So please try to assess these conditions and then evaluate and score this particular domain. Now coming on to domain 5, did overall well-being improve? Suggest using a validated scale or mention about changes in physical, emotional, and behavioral elements. Now here also, with regard to COVID-19, when the patient is, see, 80-81% of the patients are recovering naturally, or some may recover under some sort of medicines. But homeopathy has an edge. When our medicine is correct, we will see that there is no sequel to such patients. Though if they are getting well by themselves, they may have some fatigue, myalgia, or some other complaint. But when our medicine is given because of personalized and individualized approach, we see an overall well-being. So if you are observing it, please mention it. And in this particular case, you have to make a note about improvement in physical, emotional, or behavioral sphere. Like a patient may have all normal appetite after he or she has been treated homeopathically for COVID, which was initially an issue. He or she may have some altered behavior, mood swings, indifference. So please make a note to comment upon this overall well-being. Now coming on to the chronic cases, for example, I'll again take of PCOS. There can be a disease-specific quality of life scale, like PCOS-Q. So here the domains are pertaining to weight, fertility, emotions, hirsutism, and menstrual problems. So you can either use such disease-specific validated scale, or you can use a generic quality of life scale like WHO WEF. Now domain 6, direction of cure. Did some symptoms improve in the opposite order of the development of symptoms of the disease? For acute conditions, for COVID, you may not find applicable, you may not observe, but even in chronic cases, it is very less observed. So as this domain has not been validated so far, I'll request you that we all should explicitly mention the chronology of symptoms in which these develop and improve, so that we can just draw a corollary between the two. Same is the observation for domain 6B, direction of cure. Here did at least one. Initially it was at least two, but as very few cases reported and it couldn't be validated, the threshold has been further reduced to at least one of the following aspects apply to the order of improvement in symptoms, from organs of more importance to those of less importance, from deeper to more superficial aspects of the individual, and from top downwards. So again, in acute, you may not find applicable, and in chronic, if you observe it, please precisely report, so that as far as possible, so that the data can be used to define and validate it. And also, as we don't have any clear-cut guidelines defining these three parameters, hierarchy of organs, definition of deeper to superficial, and top downwards, further work in this direction is required. Now, coming on to domain 7, did old symptoms defined as non-seasonal and non-cyclical symptoms that were previously thought to have resolved appear temporarily during the course of improvement? Again, I'll say this may not be applicable to COVID cases or any acute condition, but even in chronic cases, this finding is not something which we see very often. But in case you see it, it will enhance our confidence about the likelihood of causality between our intervention and outcome. So for example, when you're treating a case of psoriasis and patient comes out, doctor, I'm having ear discharge, and when you further inquire, did you suffer that before? And he says, yes, during my childhood, but I didn't had any problem all these years. And then you inquire, are you having any heaviness, pain, or discomfort? No, it's not there. And you observe that within a few days it disappears. So please summarize the chronological sequence of old symptoms, if they are more in number, how in which these reappear. Now, domain 8. Are there alternative causes, that is, other than the medicine, that with a high probability could have produced the improvement? Consider known course of disease, other forms of treatment, and other clinically relevant intervention. See, this is a very important domain, and here if you can just go back to the first webinar where Dr. Haselen was emphasizing on critical thinking. This is one domain where we have to be very critical so that we can come out with the honest judgment. Many a times when we are successful, that biasness comes in, but this domain actually helps us to check. So in relation to COVID cases, we can say that are there any alternative causes? Our first thing should be, what is the natural course of the disease? On which day did the patient, if suppose the patient is coming towards the end of 15 or 16 days, and as per natural course, the patient is almost about to heal if the symptoms are mild. So can we associate the success of this case with our medicine? The probability will be low. Likewise, we need to inquire the patient, was he taking any herbal drinks or any herbal preparations along with homeopathy, which he might have started on the same day as that of homeopathic consultation. So that could be another possibility. So we have to critically analyze our own self, that there are there any other causes? Now, coming on to chronic cases, I'll again give you the example from polycystic ovary syndrome. There are two situations. In one situation, both the patients are having PCOS. One patient has been doing lifestyle management. She has modified her diet. She has been hitting the gym or doing 40-45 minutes of exercise. But even that is not helping, and then she's taking your treatment. Whereas in the other case, the patient is coming to you and taking treatment, and as per your advice, she started with a physical activity and lifestyle management. So in which case you'll have a stronger attribution towards the causality of homeopathic medicine? Definitely in the first case. But it is very important in the second case also to mention, so that when we are evaluating our success, we know where we stand. So therefore, all these domains should be very, very critically evaluated. Now comes domain 9. Was the health improvement confirmed by any objective evidence? Investigations, clinical examination, photographs for dermatological conditions, validated questionnaires, especially for subjective conditions. So this is self-explanatory for COVID. If possible, if we have a confirmed case, well and good, as Dr. Lefteris just shared. But in general also, in our routine practice, we should emphasize on this. Now comes last domain. Did repeat dosing, if conducted, create similar clinical improvement? See, this domain is not pertaining to the regular follow-up when you have given the first prescription and patient is coming subsequently and you are thinking of a second prescription. This is not the regular follow-up. Repeat dosing implies when the disease has been in abeyance, under remission for quite a long time, and the similar symptoms reappear and are improved with the previously selected medicine, that is to a certain reproducibility. Now in acute cases like COVID, we are hearing that there are some patients who are getting the infection again. So in that particular case, if the patient shows the similar symptomatology which he had in his first episode, and same symptomatology he's showing in the second, and he is helped with the same medicine, then it will come under repeat dosing, and we'll say yes. In chronic cases, for example, cases with relapsing and remitting causes like rheumatoid arthritis, multiple sclerosis, if the patient in first episode has come up with a kind of symptomatology helped by a particular medicine, and after 6, 8, 10 months, 1 year, when that problem again surfaced and same symptomatology is there and he is helped with the same medicine, only then we'll rate this as a repeat dosing has helped, not the routine follow-up repetition of medicine. So we have discussed these 10 domains, and the way ahead is the overarching care home case guidelines should be followed for standardized and therefore more thorough case reporting, followed by assessment of the likelihood of a causal relationship between homeopathic intervention and clinical outcome using MONARCH Causal Attribution inventory. And your take-home message for the day is we can apply MONARCH to assess the likelihood of a causal relation between the remedy prescribed and outcome in our successfully treated cases. It helps us to critically consider both homeopathic and general aspects when assessing the patient's response to the remedy prescribed. In acute COVID-19 cases, very often domains 3, homeopathic aggravation, 6S6B pertaining to direction of cure, 7, reappearance of old symptoms, and 10, repeat dosing. They will not be observed or applicable, but when present, these significantly improve the likelihood of causality. So MONARCH tool is applicable to both acute and chronic cases. A paper which further elaborates on how to work with MONARCH domains is in preparation. Your valuable experiences and suggestions are greatly appreciated. So thank you so much for your patient listening, and Vithoulkas Compass for providing this opportunity. Thank you.
Thank you very much, Chetna, for this very interesting presentation. And let's go quickly to the questions. Dr. Pritha Mehra writes, my submission that this questionnaire can be further modified a little bit, exclude questions which are applicable to chronic cases, for acute cases or pandemic-like COVID-19 cases. So what do you think?
I think I have already clarified this, that
yes.
This is applicable for both acute and chronic.
Yes.
And when we see the scoring, it is very clearly mentioned, yes, no, not applicable, or not sure. So whatever domain you find, whatever scoring you find appropriate, you can accordingly mention it.
Mm-hmm. Another topic that you have already mentioned, I think, is that in multiple, Dr. Caroline Kaur asks, in multiple prescriptions, one following another, on which one to apply Naranjo?
See, Naranjo is to be applied at the end of the treatment when we are sure that the case has been successfully treated.
Mm-hmm.
And there the causality has to be attributed to the entire homeopathic prescriptions which we have given. We cannot isolate and say that this prescription was effective and this is not, because it is the series of medicines which have been used. So assigning the causality to one particular medicine may not do the justice, because in multimorbidities and chronic cases, symptomatology is changing. One medicine is leading to another. If we go by the chapter on relationship of remedies, so what is the role of complementary, cognates, and likewise? So there we'll be attributing the causality to the full homeopathic treatment which we have given instead of one medicine.
So the modified Naranjo criteria should be applied in the end of the treatment, also in chronic cases, not to be applied in every follow-up.
Sir, it's because the purpose of modified Naranjo criteria is to evaluate the causality. When we'll apply, when we can assess the causality, when the outcome is there. When outcome is not there, in between follow-up, I don't think it is appropriate. And I'll invite further comments from Dr. Robbert van Haselen, sir, on this.
Yes, I think it will really depend on the type of disease and the complexity of the disease. I mean, there may be some cases where if even as part of a chronic disease that might, during the course of treatment, require multiple remedies, if there are very dramatic responses to one particular remedy that would really lead to very clear changes, but then there's still a shift in the symptomatology, a bit like the disease evolution concept that would then require another homeopathic medicine to complete the disease evolution towards cure. In those circumstances, I could imagine that even on a single case, there could be assessments after one particular medicine, and then because the symptomatology has shifted, there could be even a second assessment on that single case of the second medicine prescribed. So I think it's really, it depends a bit on the complexity of the disease and the judgment, the clinical judgment of the practitioner.
Okay, and this was the question also of Dr. Ritika Hisia Narula. Okay. Another question of the same is that what should be the cutoff value of MONARCH?
Yes, it's this question I was expecting. And after this webinar, you will send the HOM-CASE CARE guidelines, Naranjo criteria, this MONARCH criteria, and the case report, which Dr. Lefteris just discussed. You please assess it, fill the scores, and the scoring detail we'll be discussing in the next webinar.
Okay, and from the same doctor, what should be the precise clinical applicability of modified Naranjo criteria so that it is not misinterpreted? As it's seen that people are applying this criteria in their research studies protocols without knowing its exact clinical applicability.
The exact clinical applicability is to establish the likelihood of causality, because case reports are considered the weakest level of evidence. So how can we improve the evidence? How can we improve the causality? That can be done only when we are sure, when we have some objective parameters in our hand that patient has improved, the case has been treated. As sir has rightly said, depending on the nature of disease and complexities of the disease. So only after that, we should ideally apply it. It is not a tool which has to be applied at every follow-up because it will lead us nowhere, I suppose. Only when we are sure we have treated, like in this particular case, the patient is absolutely normal, she is fine, she has resumed her duties, she is back to her normal self. So at this time, if we apply MONARCH, it makes sense. But if we apply it when her fever has just dropped down, then we'll not reach to any conclusion. So only at the end of the treatment.
Okay. Dr. Susan Ulbrich asks,
can I make very brief?
Yeah, of course.
Because sometimes I get the question that people say, well, in my daily practice, it's just too complicated to do a whole questionnaire like this. And I also appreciate that may not always be feasible. So then in that case, I always advise to do one very simple thing, and I explained that in my first lecture, where I said, just have a negative test strategy. Instead of believing and thinking, oh, most likely the changes I'm going to see in my patient are due to the medication, just be a scientist and say, no, I'm going to apply negative test strategy, meaning just for a moment, if I imagine that my remedy had nothing to do, that my remedy was a total placebo, it didn't have any effect. And then you look at the changes in your patient. And if then under those circumstances, you can say, yeah, but I cannot think of anything else that could have occurred that could explain a change of this nature or scale or size. That is something as part of your routine clinical practice can give you already some sort of extra confidence without filling out the whole questionnaire.
Okay,
so critical thinking, which you elaborated in the first webinar, that was actually very important and base for further sessions.
Yes, and I emphasized also that the structure of this case report is very similar to the structure of scientific investigation when you report any kind of scientific effort. And scientific investigation, the basis of scientific investigation is the so-called null hypothesis. And in your null hypothesis, you deny you're saying you want to prove that homeopathy is more than a placebo, for instance, in a clinical trial, then your null hypothesis is homeopathy is a placebo. And so it's exactly the same logic when you apply this in your daily practice, that you say, well, your hypothesis is that you assume that your remedy, the similimum, which you hope is a similimum, will have triggered a certain change. But your null hypothesis should be, let's assume now, just for a moment, that my remedy was totally ineffective. How likely is it, am I to observe what I see in my patient? So it's exactly the same way of thinking.
Thank you, Robert. Dr. Harleen writes, I think that this makes sense, Dr. Chetna, doing so at the end of the treatment, but then we can't report the effectiveness of one medicine for future studies. I think this is something that you have said already, Robert, that we have to judge and act in each case accordingly. Okay, another question from Dr. Susan Ulbricht. Is it really reliable to use the numbers of the MONARCH criteria? What are the criteria to choose which number? Are these numbers allocations validated?
No, number allocations, I think Dr. Robert will be able to better answer this question.
Yes, again, I think it's a very relevant question. And having also worked with Dr. Lamba for many years on this project, and even within the homeopathic pharmacopoeia of the United States, with many discussions about what's the role of the scoring and what's the importance of the score. And intuitively, everybody would feel that, okay, if the score is low, you're less confident. If your score is high, you're going to be more confident. But where do you draw the line? And that's quite a difficult discussion. And I think that's why we decided that, because today we had quite a full program, that we will go next week, address this topic in depth, where we will really try to give you some sort of a guidance on how to use the scoring. And also, well, is the scoring maybe different in acute cases and in chronic cases? Because some might argue it should be different. So if you want the answer, we look forward to seeing you next week.
Okay. Dr. Niraj Gupta, in Naranjo criteria domain 5, don't we get bias in COVID cases having anxiety wherein validated scale may not be possible to apply and only verbal counseling may help? How can we judge whether the medicine has helped or counseling?
See, this I have answered, because if you're not using any validated scale, you can comment upon the physical, emotional, and behavioral elements. For example, the appetite is altered, the sleep is disturbed, the emotional thing is disturbed, the patient is very labile or patient has become indifferent, morose. So there could be any possibility. So accordingly, what you see, you need to write and remark on the physical, emotional, and behavioral aspects. I think that can only help us to evaluate the overall well-being. And second thing is the sequelae. As natural course may have sequelae, patient may have the poor appetite continuing for days together. If you observe these things, that counseling is not helping, or the appetite or the other general symptoms are not returning to normal, it means that overall well-being has not been helped.
Yes, thank you. Another question about the domain 8. in cases where homeopathy is being used as add-on to conventional medicines. How to evaluate domain 8?
Yes, there we have to write the limitation in our case report that it was given as adjuvant to conventional treatment, and there we have to study the other case reports. We can bring this in discussion and we can see what was their outcome, and we can answer this aspect in our discussion by studying the cases which are only on conventional treatment.
Okay, thank you. Now this is a question for me. Please justify muriatic acid prescription. Muriatic acid was the second remedy after the pyrogenium. I think the doctor prescribed this medicine because of the marked weakness that was continuing after the fever has dropped. If we have the chance at the fourth webinar for the doctor to present this case, because this is a very interesting case, we may ask again on which points this prescription was based on. Okay. A question about Eirini's case. Eirini did not mention a COVID-19 case. Eirini told us how to submit a case and gave us an example of a pneumonia case from the literature. Okay, we have another question. As per CDC China classification, this was a mild, moderate, or severe case. I'm not aware of the China classification. I don't know if any one of you knows this classification. The doctor can send us through email this classification and we can see it because I'm not familiar with it. What are the ways to submit patient experience after treatment in case report? The patient experience. I show you an example where we had a narrative from the patient. I don't know in what other ways can they submit their experience, Robert? You are muted.
I think, yes, it's really about the narrative of the patient. So it could be either a full narrative like we have in this COVID case, or it could be some excerpts. But the main idea is that we should enable us to transport ourselves into the experience of the patient, her or himself, via verbatim, either citations or the complete narrative.
Okay, about the narraggio again in point 8, negative marks is more to other cause, which deducted more scoring point from total score. Is there any requirement to reevaluate the point 8 to equilibrium the both? I'm not sure I have understand this question.
Sir, I'd like to answer this question.
Yes.
It is actually very critical domain where we have to doubt our own success. When we say that we have successfully treated, so is it actually attributable to our homeopathic intervention, or is it attributable to some lifestyle modification, or some spontaneous remission? So there are n number of confounders, and case reports as such, they have they are considered the weakest level of evidence. So we need to evaluate this particular domain very critically by ruling out all possible confounders, and I think that is the probable reason why it has been given as -3 if we find any other reason for success in the or treatment.
Yes, this is similar. Has the minimum score required to attribute causality to the intervention been standardized, and if whether it differs in acute and chronic cases?
We'll revisit this in next webinar.
Okay. On how much percentage change in the outcome will we access MONARCH? Is any cutoff suggested where the cases included in the study has specific outcomes?
So scoring, as we have just discussed, we'll be discussing in the subsequent.
Yes. How to apply Naranjo criteria in treatment of those diseases conditions where symptoms develop at a late stage. For example, in aortic stenosis, symptoms may appear at a late stage.
Other domains like your objective evidences, and there is no other alternative cause for treatment. Improvement in the main complaint. So this will depend on the case, what kind of case the patient is having, complaint the patient is having.
Okay, another question about the MONARCH, about the well-being. For accessing the domain of well-being in MONARCH, can the physical activity score and well-being score in a MIMOP-2 scale can be considered if a generic specific quality of the life scale is not filled?
Maybe I should comment on that. I think it's a good question, but MIMOP is really about what I understand of MIMOP. It's a validated outcome measure, but it's an outcome measure which is focusing on a symptom, a main symptom that is attributed by the patient themselves as being their main symptom. So I don't see how it could have any relevance for the general well-being. I think it's really about the MIMOP should be used for changes in the main symptom and not for the general well-being.
Okay, thank you. And Dr. Susanna Aziz asks, in research like clinical verification projects, modified Naranjo criteria and ORIDL scores are being used. Is it a right approach if we access Naranjo when we are getting an ORIDL score more than 2?
See, for clinical verification, first of all...
Can you first tell us something about this ORIDL score, because not everyone is aware of it, is familiar with it.
Details we'll take subsequently, because we have to clear the concept, what is clinical verification and how it is going on. So we'll take up it subsequently.
Okay, and the last question I have from Dr. Harleen again. Can VC come out with a quick analysis of rubrics most frequently being used in COVID-19 for everyone's knowledge? Yes, at the moment we are collecting cases, and it is in our plan to do this when we have enough cases to show you, perhaps also in the next webinar, if we have enough cases, to show you the most frequent symptoms that are being used, and also the most frequent remedies. So taking
Can I comment,
this,
Lefteris?
yes.
Okay, so yes, I think we will present in the next webinar the most common rubrics and also sub-rubrics, and also some of the remedies that have been prescribed and which were more used in COVID cases, but we're still in the process of analyzing the cases and we have not reached conclusions yet, but we will present some of our findings in the next webinar.
Thank you, Theodore. And with this opportunity, I would like to repeat the contest that we have. We encourage you to send us your cases, and the best 2 cases will receive a prize as a 6-month free full subscription in Vithoulkas Compass. And we will also help you, mainly Dr. Robbert van Haselen will help you to publish these cases, to how to make a proper case report, and also Dr. Chetna Lamba. So I make again this call to send us the cases. We will send you, after this webinar, Eirini's presentation of how to send us the case. We will send you the checklist of HOM-CASE CARE guidelines. We will send you also the LMHI form and the 10 case Naranjo criteria, so that this work will make you, so that you will get help for sending your case. Okay, one more question for Dr. van Haselen. Yes.
Sorry, Lefteris, if I
Yes.
would like to add to that, that we will also share the case that we presented today, the COVID case, and we would like everybody to prepare themselves, read this COVID case and prepare themselves with the, on paper at least, with the Naranjo score, because the explicit purpose of next week is also that we're going to deepen our understanding of, if we work with the MONARCH, sorry, I apologize, Chetna, if we work with the MONARCH, how can we apply that? And so next week will then also be an opportunity to share that feedback. And then, of course, next week we will also address this topic of the score, the level of the score, and the relevance of that for using this MONARCH inventory.
Okay, thank you, Robert. A question for you from Dr. Kyriakis Stefanidou. Aside COVID cases, would you urge us to use other standardized questionnaires that you think we could incorporate into our daily practice? What you'd suggest? Could those also be part of the MONARCH?
That question for me?
Yes, questionnaires about COVID cases.
Well, I think the MONARCH really addresses this topic of causality, likely causality, and any other questionnaire that addresses other aspects like quality of life, like maybe some developed questionnaires people out there, questionnaires which are published to assess outcome in COVID patients. All that would always be welcome, because the more objective, the more we can objectify any changes using validated questionnaires, the better. So in general, my answer is yes, as far as available, we should always try to use that.
Okay, thank you, Robert. So, see you again next week, where hopefully you have this homework to see the COVID case and see if Naranjo criteria are applied and make your score to it. Next week, as we said, Dr. Theodore Lilas will speak, and hopefully we'll have some symptoms to show about these cases. Also, Dr. Van Haselen will speak in the next webinar as well, and me to show you around the repertory with specific reference to COVID cases. What else? This webinar is also being recorded, and you can find, we will also upload it in in YouTube. You can search for Vithoulkas Compass on YouTube, and you will find also the first webinar as well. I think that's it for today. Thank you very much, and see you next week. Take care. Bye-bye.
Goodbye.